I'm Dr. Anthony Cave, and today I have a story about a patient who was so terrified about having surgery in a room just like this one, where they nearly walked out the room after everything was getting ready for surgery because they were terrified of a rather unique concern. They were afraid of having this breathing tube in their mouth. This was a young lady. She had suffered a trauma years ago from someone placing something in her mouth against her will. And she had oral sensitivity since then in ways that brought up, understandably, traumatic experiences. I don't want to diminish this individual's horrible experience that occurred in the absence of adequate support. But I will say that given the type of surgery that this individual needed, there was no way around placing the breathing tube and placing the laryngoscope into their mouth for them to have a successful and safe surgery. Are you guys familiar with the endotracheal tube? Let me know in the comments below, and I'll go into it in our live at the end here and answer your questions about why we need this tube, why it's such an important part of surgery. As you know, we're live here, so I'm keeping track of all of your comments, and I'll answer them as they come on, for ones that are educational, for others. But not to worry, at the end, we'll have plenty of time. What did I do for this patient, though? This patient who wouldn't be able to even have this surgery, which was elective, but not something that they could postpone forever. There was something in their abdomen that had to come out. And if we didn't get it taken out today, I don't believe there would have been any way to convince her to come back again to the operating room to have this removed. And if this stayed in her abdomen long enough, it would have been lethal. So I'm very curious what your thoughts are about what you would do if you had a patient who needed to have surgery but was afraid of the breathing tube. And you're right to recall here that, as you know from our previous videos, the breathing tube goes in after you're asleep. And yes, it would be very unethical to put someone to sleep with anesthesia and then do to them what they did not want to have done. So in the absence of breaking patient trust and breaking their informed consent, what would you have done? And then I'll tell you what I did. Hawk in particular says, I've woken up with it still in my throat. It was terrifying. Another reason why some folks have medical PTSD. Phillips is talking about doing a block. Unfortunately, this surgery could not have been done safely with just an epidural or just a spinal block, so they did have to go to sleep with the breathing tube. Candy says, talk them through what you'll be doing. Tried that, didn't work, but you're on the right track. We are getting closer. Explain the process, says Georgia. That's kind of what I'm getting at, and I'm doing it with a special aid because simply explaining the process is bringing up traumatic memories in this particular patient. And reliving traumatic memories, remember, the body keeps score to a degree, and I don't want to keep reinforcing the negative association with something in someone's mouth against their will. So with that said, I had to do something a little bit different. When someone has had a trauma before, when they are re-triggered in the exact same unsupportive, unchanging environment, that has a high likelihood of reinforcing the negative trigger. If you know what I mean, let me know in the comments. For example, if you're afraid of turbulence on an airplane and you keep sitting in airplanes where there's a lot of turbulence and no one is there to help you, it will likely intensify your fear around that turbulence. If one can intervene and provide the support to help break that brain connection, which is sometimes as deeply ingrained as a spinal cord reflex, it's not like someone is purposely freaking out of the turbulence or purposely freaking out of the breathing tube. There is a deeply ingrained association that can be broken with certain mindsets, including the mindsets that can be facilitated by anesthetics like what I'm holding here, which is propofol. And this is where the ketamine comes in as well, that we'll talk about. What I did with this patient was a lot of legal considerations. I explained to the patient, ma'am, I know that you want to have this surgery. I'm acknowledging what they want. 2, I know that you are concerned about having something involuntarily in your mouth. Acknowledging their concerns. 2. And number 3, I said, ma'am, if we all agree to provide anesthesia for you with a low enough dose that I can then walk you through the process of placing the breathing tube. Would you be okay with me continuing with however you respond in the moment? This is very carefully worded and needed a lot of people to be witness, because doing a procedure on someone who is sedated is not right, because they're not in the right state of mind to consent to a procedure. Discussing this before they get any sedation, however, given this extenuating set of circumstances, is different enough that our legal team and my fellow physician agreed that this would be reasonable, given that the alternative is her not getting surgery today and maybe never again. I gave the patient a low dose of propofol, and I gave them the breathing tube, and I asked them to put it in their mouth like this. Sorry. Ordinarily, this would never go in their mouth. With a little bit of sedation, allowed for breaking that negative association, that deeply ingrained reflex, that not only were they okay with it going in their mouth, but they said, "Doctor, I am ready for this surgery now." Was it going to be, did I anticipate it being that smooth? No, but it was that smooth. The surgery went perfectly fine. The anesthesia went perfectly fine. And I used my special concoction of medications to help minimize the risk of emergent delirium. And as some folks already mentioned, waking up with something in your mouth can be terrifying, especially if it's between your vocal cords. So I had to wake them up in a way where I was as confident as possible that it would not be there when they regained consciousness. They did not have any worsening of their PTSD symptoms. And in fact, they have had surgery since without the need for that anesthesia-augmented exposure therapy. Folks, this changed this individual's life, and it was not done by slamming anesthetic and ignoring what they said. It was done by spending an extra 30 minutes, which, yes, throws off the whole surgery schedule, I understand. But this is a human being's life that we just were able to break a cycle of continuously compounding medical PTSD. Now, folks here are asking me about ketamine, and this is where ketamine has a rather powerful effect, almost like Jane's saying, to augment a hypnotic state. Hypnosis is nothing more than being in a suggestible state. And if we can harness a suggestible state to improve someone's well-being and their relationship around maladaptive behaviors, like walking out of the surgery room, that can be a significant benefit for the patient. When we are doing this with IV ketamine therapy, we do similar work with a therapist, with informed consent. Of course, this is very delicate work. And if it is done in a way that augments the patient's ability to harness their inner locus of control, can allow for long-term benefits. The same for the stellate ganglion block that I do as well, by reducing the sympathetic surge or that fight-flight response that can reinforce these negative associations and sometimes prevent patients from getting the care that they need. And just like Candy is saying, validating them by listening to them and taking the time to find a way that they're comfortable with it is huge. It's not that big of an ask when we're spending tens of thousands, if not hundreds of thousands of dollars here in the operating room for surgery. I think we could spend a couple extra minutes to help you or someone that you know or love feel comfortable with the process. If you have ever experienced this before, please leave a comment below to share with others. I know from our live comments that many of you know exactly what I'm talking about. If you've learned something new, please hit the like button and share with your loved ones, especially if they're having surgery. We're going to jump into our live Q&A now. Please remember that you have more power over your health than you've probably ever been told. And it's by acknowledging and harnessing a state of mind where healing can be found that we can often do with one exposure, like in this case, one exposure with propofol, to do what lifelong medications are unable to do. And I'm talking about things like SSRIs and SNRIs and TCAs and benzodiazepines and all other new forms of medications that don't always address the root cause. Monica, I very much appreciate your kind comments, and same to you, Jodie. Rosalind says, I need a fusion foot surgery. Still haven't had it because I'm terrified of anesthesia. I also suffer from severe anxiety. Rosalind, I hope that this story has given you a little bit more of a framework of what could be done, perhaps in your case, to help you more safely have that foot surgery that may well help you, I don't know, walk again, run again, be able to do the things that you want to do again. Cece says, bolting out in a gown is definitely maladaptive. Yes, it is. Yes, it is. Hi back from the San Francisco Bay Area. And Caitlin, I'm happy that you found this interesting. There's a lot more to this story, but this is the bird's eye view. Adam, I'd like to hear him talk on the use of dexmedetomidine. I'm a big fan of dexmedetomidine, and I used it in this patient as well. Actually, I was about to grab it out of the drawer to show you all, but you already brought it up, Adam. Very, very powerful medication for folks who have PTSD. My surgeon used humor to calm me. That's wonderful. Deborah, yes, lady, I've moved to the Ozarks, and acorns falling onto a metal roof is pushing me over the edge. I'm sorry about that, Deborah. Jodie, I appreciate your kind comments as well. Deborah has PTSD from carjacking. Unfortunately, I practice in the San Francisco Bay Area. There's a lot of carjacking that happens here. Folks who have been traumatized from some sort of crime in the past. It's not a one-size-fits-all approach. However, recognizing the trigger behavior reward loop that underlies many maladaptive reward mechanisms or maladaptive processes, even in cases of severe PTSD or the potential for severe PTSD, can find relief from these types of interventions. I'm not saying everyone has to get ketamine or everyone has to get a stellate ganglion block, but we need to find a state of mind that allows us to break that cycle, either with neuroplasticity from an external source or from an internal source, of which there are no shortage. If you know what I'm talking about, let me know in the comments. I know many of you do. Methylene blue. I am not referring to that here in terms of neuroplastic agents. Julia just had one in May and just finished recovering from foot surgery. I might need another foot surgery. I'm hoping you don't, but if you do, I hope that you certainly don't have any PTSD. I'm going to use the word baggage. I don't mean it in a negative way, but any type of negative experience that you're carrying forward with you. And by the way, for those of you who are learning, you can always join our membership program so that I can see your comments more easily and helps support me to do this for you more often. I look thinner. Suleiman, I got a haircut. Maybe that's helping. Look, contributing. I don't know. Classical music for me. PTSD from 2 armed robberies. Georgia, I'm very sorry to hear about that. And I'm happy that classical music helps change the otherwise ingrained loop from playing out, if I'm understanding you correctly. Ooh, Lushpa, please tell me why they would keep a patient in the OR for 90 minutes under Versed before they put them under. My record says I went into the OR and was put under 90 minutes unaccounted for in records. Lushpa, I wasn't there. I can't say for sure, but sometimes it takes time to prep the patient, clean the patient. Maybe there is, I don't know, some positioning that has to happen. These all can take time between the anesthesia induction time and when surgery actually starts. Many, many explanations, but I wasn't there to be certain, of course. Is it normal for someone to forget how to breathe? Enzo, folks who have a severe dissociative experience, I've seen them, breath hold. Patients who are waking up from anesthesia sometimes hold their breath as well. Is it the same phenomena? I don't believe it's the exact same, but I do believe that when we are in significant fight-flight responses, we engage into that primitive behavior to breath hold. If you know what I'm talking about, let me know. Caitlin, I'm so happy that you enjoy watching these videos. I'm sorry that you're a brain trauma survivor, and I'm sure you're very familiar with so many things in medicine, all of our jargon, our cheat codes, but I'm happy that you're still learning more. And you're very welcome, Adam. Heather, so good to see you on here. Yes, I suspect it is the haircut. Wesley Barton, thank you for being a member. I'm so sorry to hear about You're abused at 12. My scoutmaster had panic attacks, afraid of crowds afterwards. Well, Wesley, I'm very sorry to hear about that. I hope that you sought professional help for that. These are more examples of when sometimes the maladaptive fears that arise from that PTSD can be improved by breaking the cycle through a neuroplastic agent. Like I said, it's not just external medications. Many internal states can do it as well. Martial arts is empowering, CC. I'm happy to hear that that has been your experience. And let's end with Crystal's question. Can you explain the risks of hospital delirium after major surgery? This is a major concern because of the risk of delirium in certain patients being a harbinger, either through association or causation, of future dementia. Is the brain being damaged when there is delirium happening after surgery, or if you're in the ICU? Quite likely there is some degree. Most folks will not have a lasting detriment because if you're young, your brain has so much reserve that it's not going to get a serious hit from that. But if you're elderly and you have less cognitive reserve, even knocking out a couple parts of your brain, figuratively speaking, might manifest as impaired cognition. This is still a very active area of research, and it depends on many factors, like were benzodiazepines given or other medications that might contribute to delirium? Was it delirium from maybe having brain surgery or untreated pain or having altered vital signs or having heart failure? It's difficult to know for certain. There's a lot to tease out. But the precautionary principle, everyone who's listening, is to help minimize the risk of delirium. Using melatonin in the ICU if need be, not having people check your vitals if it's unnecessary overnight, having family members nearby to help coordinate your sleep schedule so you're not sleep deprived, on top of having pain medications and sedation medications, putting your brain in a worse and worse place. The less cognitive reserve you have, the higher the risk of long-term consequences. I hope that answers your question. John, I will have to quickly say here that THC absolutely can affect your reaction to anesthesia and should not be used before major surgeries. And I'm so happy that folks like DJ Fire Queen, who has an awesome username, by the way, agrees. Heather, thank you so much for your kind comments. And I hope that you all learned something new to better advocate for your health, to get the care that you deserve. As always, please share what you've learned with your loved ones. And if you learned something new, hit the like button and consider joining our membership to help me do this for you more often. Until next time.